Hey everybody, welcome back to the Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim. Got my usual co-host over there, Dr. John Hill. And returning for third or fourth, or I think you have gotten the award. You've surpassed Dr. Spanner for the most visits to the podcast. We got Dr. Jordan Singer here. Hey, welcome back. It's always a blast to have you. We got something kind of a little. It's medical related, but it's kind of a little off topic, and it's that kind of that pestering thing. I suspect that every medical provider at some point has been like, oh man, what if I'm on an aircraft and that dreaded overhead page comes, is there medical trained personnel in the aircraft, somebody that can help? And you have a kind of an interesting background in that space that a lot of our medical director colleagues don't have. And how do you have an interest in this, and what's that background look like?
Yeah, so as we talked about before, I as a part of my fellowship at UPMC in Pittsburgh, we provided online medical control for in-flight emergencies for a few different airlines. And so this was just so that the captains had confidence that things were okay, or they could get advice, especially if they didn't even have any medical trained personnel. So It was just to provide additional insight in real time for issues that happen at 30,000 feet. So it was a fun experience because it's definitely a different world.
Yeah, I can only imagine. And you have absolutely, let's say somebody is up there. You mean they could be a nurse, a doctor, a paramedic, anybody. So they page, like I said, the page goes out overhead. Is anybody that can help? How do they wind up talking to you? How do you wind up talking to the crew? What does all that communication look like? Or is that person just up there kind of doing things willy-nilly and just...
Yeah, so they don't always call for some emergencies. If it doesn't seem that concerning, they might just not even bother calling if they have no intention of even considering diversion. But if there's any concern, there'll be a process where the plane will call a dispatch center of sorts that is regional, and it's via multiple phone connections could make it to my cell phone if that was happening. And so I did this for a little bit, even for the first 6 months I was here in Cleveland, where I did it remotely. So I would be in Cleveland with getting paged from Pittsburgh, which was somehow making it to an airline. And so in those situations, obviously the captain is still trying to fly that plane, and kind of the captain has to make their own decision if they're going to land. That is not my call. In the end of the day, I provide advice, and the captain, it's their ship. They decide what they want to do. And oftentimes they default to the advice we're giving, but then we have to somehow communicate with the captain, who's trying to communicate with someone that is in the back of the plane with the patient. And so very frequently I can only ask one or two questions, because trying to ask anything more than that and have telephone go on, it will never actually get an answer. It was definitely a fun experience trying to figure out how to ask the specific questions I need to give the best advice to the captain, which was often just lay the patient on the ground and lift up their legs, because often the patient is just passed out for a number of reasons, and in the next 5 to 10 minutes they're going to look way better.
Yeah. So what happens at altitude that causes us issues, right? So how is that any different than somebody here at sea level, or near sea level, or on the ground? What do you have to contend with up there as far as variables for their case presentation?
Yeah, so there's a couple key differences. The first is definitely changes in physiology. So the cabin is depressurized to 5,000 to 8,000 feet, the equivalent of that elevation. And so that's similar to Denver. So if you are in Denver and you get in a plane, you're probably not having much change in your physiology. But if you're coming from sea level, then you have decreased kind of partial pressure of oxygen, which means that the percent oxygen is the same, but there's less getting kind of forced almost into your blood and your lungs. And so your normal sat down at sea level might be 100%, which then could get pushed down to the high 80s if you are at altitude and the cabin is being depressurized. And so if you're a normal person with normal lungs, not a big deal. But if you maybe have COPD and you're fine normally, or CHF for pulmonary hypertension, this could potentially push you over the edge and take you from being totally fine at sea level to having a bad time at altitude, which is not close to the ground. The biggest problem is if the captain decides to land that plane plane, it'll take probably 30 minutes or more to go from that decision to being on the ground. Then you have to get off the plane, and then you have to get to the hospital, right? So you're pretty far away from care when you're at altitude. And that's if you could land immediately versus you have to fly to a different airport, factor for weather, or the worst, if you just took off, you can't land when you're that heavy with all that fuel. So you have to dump the fuel, and then they could land in that situation. So it's tough.
It sounds like a very expensive proposition to divert.
It is, and that's why most of these airlines do not want to do it unless they have to. And so ultimately, they will absolutely land that plane if they think it's in someone's best interest. But what they don't want to do is have a false alarm where something sounds concerning, and then they land that plane and realize everything would have been fine if they had just continued. And so that's the whole point of calling us is just to ask, hey, does this sound like something we should continue on for, or should we land this plane right now? There's certain things that would say definitely land this thing. There's certain things to say let's just give it 10 minutes and see what happens. Most things fix in 10 minutes.
That's the rule of in the aircraft, huh? Give it 10 minutes?
Well, that's what we'd frequently do is say, here, this sounds reasonable, do X, Y, and Z. Call me back in 10 minutes if things are not improving, and I'll have new advice, which is often we'll land. Reassess. And we'd often base that on where are you? Like if we have 10 minutes before the next point where we have to pull the trigger on landing, then we might as well wait. Now, if we're about to fly over a big pond, such as the Atlantic Ocean or the Pacific Ocean, we may pull the trigger a little earlier and say, hey, this is potentially going to be a real problem. Based on where you are right now, I would consider diversion. That's how I always say it. Not you should divert, consider it, because often it's not my call. It's the captain.
Do you have that same level of communications if you're over the pond? I mean, if they're in transit internationally, can they afford that same level of communication back regarding medical direction and medical suggestion for these cases?
So if you're already over the ocean, then it's actually quite easy, right? There is no place to divert. You're just going to say, this is how far away we are from the nearest chance to divert, so let's figure out what we need to do there, and we can reevaluate the closer we get on what we need to do. And that's the other thing is especially flights over the Atlantic, they kind of veer north just because it's a little bit shorter when you consider the globe. But then now the part of the land you're the closest to is very northeastern Canada, and there aren't major hospitals there either. So that's the other thing is the first part of land where you could land someone may not even have the services you need.
If I can get on the ground, I'm
not going to land someone who I'm worried has a heart attack if there's no cath lab anywhere nearby. We're just going to continue further to get closer to a cath lab in that situation.
Did you have some reference material for that, or was that kind of just quick Google search? So cath labs in Greenland.
I did not have that, but we had communication specialists that was called ComSpecs that they had all this. And so what I would do without off the radio, but just to them is say, hey, where is the nearest airport that we could land a plane of this size that has X facility nearby, and they already have done the research and have it all ready to go.
That in and of itself is just a monumental undertaking, just sorting that logistics part out. Yeah, that's crazy. How so the respiratory stuff is kind of again the low-hanging fruit with at altitude. Are there other medical issues, problems, concerns that were the more frequent of the cases that you handled?
So the respiratory ones are the obviously the most common. But the other thing I forgot to mention is the reason that people on planes often have medical emergencies is they're not necessarily taking care of themselves in the 24 hours prior to travel. People are often getting up early, not sleeping very well. Maybe they missed their medications because they packed their meds. And maybe somebody's coming back from Vegas and they clearly were well rested while they were at Vegas. And so all that is a recipe for something to happen on a plane. And so the most common by far, and this is based on data from one of my colleagues who I trained with in Pittsburgh, was that a third of the time it ends up being syncope or presyncope, which is almost always what it is. And it's rarely an arrhythmia. It's typically somebody vagal down or was nauseous or something. So the fix for that is volume down, some juice and lay them on the ground, and they'll just get better on their own, which is always why I say just lie them on the ground and elevate their feet and call me back if something changes.
That's
the next most common would be GI stuff, so somebody has nausea and vomiting, maybe they haven't been eating very well and a little bit before. Then there's respiratory, and then there is cardiac stuff, but that's by far a minority of cases, and then a smattering of other things.
And I imagine that's what everybody's worst case scenario in their mind is working a cardiac arrest at altitude.
Yeah, you're pretty far away from help, and you don't have much. I mean, the EMKs, the emergency medical kits that they have on all the airlines do have some things. There's atropine, there's a couple doses of epi, there's a BVM. You do have a couple very small cylinders of oxygen on the plane, but you're very limited, right? Like that's not enough to do. You don't have a monitor. You do have an AED, so you have a few things. But I mean, if you're working a cardiac arrest over the Atlantic, that person's not going to do very well.
Are there any particular considerations with using an AED in a aircraft?
Nope.
Yeah. So
nope, nothing to worry about. Just use what you have in those situations.
Go to work. Nice. And I assume if we have epiatropine, all that, we've got vascular access.
Yeah, you have a couple IVs. You have, I think, a half-liter fluid, or probably half, not a full liter. You have very little stuff, and a lot of this stuff is mandated by the FAA. So the EMK has a minimum amount of stuff that you have to have, and very few airlines, if any, have anything beyond that, because every airline must have, or all their airplanes must have it fully stocked and ready to go for every single flight. And if it's almost never used, that's weight. And so ultimately, they don't want any extra weight that they are almost never going to need.
Sure.
Just that weight is fuel's money, and so they typically don't add anything else. Some airlines have added Narcan, which is not standard, but that's an extra thing. And some airlines have added Zofran, even though Zofran's probably not going to save your life. They just don't want to deal with someone vomiting everywhere.
All over there.
Zofran was low-hanging fruit.
It's the cost to clean up the aircraft that they're sidestepping.
So my wife actually paid attention to this month's episode. She's like, "Oh, did you know they don't have EpiPens on board?" I'm like, "Well, that makes sense. They have Epi, but they don't have the auto." Most. It's not required by the FAA.
You're right. I think they might have the right concentration, but they don't have the EpiPen because that's extra weight.
They don't have the auto injector.
Right.
So if you're used to doing an auto injector, or if a layperson's like, "Oh, I can do an EpiPen," but they don't know how to draw up IM dose Epi and then give it.
The one thing is that many people who have allergic reactions obviously carry the EpiPen with them. And this is the time, if you're ever dealing with a medical emergency on a plane, ask around. And now it's like, hey, does anyone have an EpiPen? Obviously, if we were there, we could just draw up the Epi and do it. But don't be afraid to kind of say, to be a little creative and try to figure out if there's someone else with something that you need that would be willing to share, like throwing an Apple Watch on someone, which we chatted about a little bit. And then the other thing is if somebody is, this was my colleague who did this, where they had a guy on a plane who was clearly in alcohol withdrawal, and so he just basically told the stewardess to open up the bar for this patient so that he didn't seize and have a bad outcome, because alcohol will treat alcohol withdrawal and will buy time to get him to rehab, which is why he was on the plane. He just needed to stop drinking after he landed, not before he took off.
Yeah. Wow, that's quite a story. Wow.
So our behind-the-scenes person that cuts up these episodes and makes our shorts, like the fact I said, like, here's your beer, because we said that in the podcast. I'm like, that's how we used to treat. We used to let alcoholics drink in the hospital.
Moderated.
And there's beer, and we would have to write for beer to be delivered with every meal to stop them from withdrawing from alcohol. Before we had good treatments for it.
Well, that's the thing. Even nowadays, it'd be reasonable to treat people with alcohol for that.
Absolutely.
Because the first thing I ask someone is in that situation is, do you intend to stop drinking? And if the answer is no, okay, well, you might as well continue to drink beer, right? You're not ready to quit. When you're ready to quit, come see me. I'll help you. But if you're ready to quit, we can use benzos or phenobarb or other stuff. So.
Awesome.
Yeah.
How, we kind of got talking about some of the nuts and bolts here. How often is this happening? Is there an in-flight emergency, and then subsequently, how often do those require diversions?
Yeah, so the same data based on when I mentioned like syncope, pre-syncope, 33% of the time, that same study showed that I think it was 1 in every 600 flights had some form of quote-unquote in-flight emergency. So this is just some call for medical assistance.
Right.
And most of those aren't true emergencies, they're just something. And then I think it was about 5% of those are diverted. So it's 1 in 20 medical emergencies on a plane will lead to diversion. And that may not even just have been a true emergency. There's times where the captain may have already said, I'm diverting. This ship is sailing, I'm going to do it. And if that call came into me, I would say, all right, how can I help you?
All right, cool.
What resources waiting for you when you arrive on the ground kind of thing. So, but it's not very common. And I mean, I've been on many flights, and it wasn't until about 3 weeks ago that I was on a plane for a medical emergency. And then when my wife kind of elbowed me saying they're asking for doctors, and I told the stewardess that, oh, we have like 6 other doctors already. I'm like, all right, I'm just gonna go back to bed.
You got a dermatologist.
They didn't seem stressed out, and I was like, this is good enough.
Right.
Call me if people start yelling. What I thought was interesting during our recording episode, talking about, so if they're going to divert, right? Let's say I'm flying New York to LA, and I'm over the Rocky Mountains and actually choosing where your diversion destination is going to be. So if the story is a patient's having what sounds like a MI, you don't want to have them land at the closest airport and then have to helicopter the patient to the closest STEMI center, right? So being able to know what resources are available and where you're going to decide, like, okay, well, it's actually going to make more sense you're going to divert to Nevada than, say, like Colorado, because you're going to be much closer to the services that you need when you get there.
Right. And that's the thing is the final decision is always the captain's, and what we'll do is we'll say, hey, this is what we're worried about. These are the airports that have the services that nearby that you would need. Where do you plan on going? And so then they make that decision, and we're like, okay, great, we'll let the hospital know, we'll have EMS waiting for you, we'll tee everything up, and here's some extra advice on what to do with the patient in the meantime. That's kind of our main job, is to just help them achieve the goal of getting the patient where they need to go.
Awesome. So if one does elect to intervene, what am I permitted to do as a paramedic over, we'll use his New York to LA, right? I'm somewhere over Colorado with an Ohio certification. How does that play out, and what am I permitted to do at 30,000 feet?
Yes,
as an Ohio paramedic?
That's a good question, and ultimately it's kind of getting down to liability and like what you're allowed to do. And so the American Medical Assistance Act basically is the Good Samaritan law for airfare, and so it basically says that you're allowed to do anything you're trained to do, and you have protections from that, from liability, unless gross negligence is involved. So as long as you don't do something crazy or something outside of what you were trained to do, you are fully protected. Now most Good Samaritan laws say that you can't receive payment for that. So one could argue that if they upgrade you to first class afterwards, or give you alcohol or something, now that could void that if it went to court. Possible, but at the same time, the odds of you being sued for going out of your way when you're on your vacation or something to help someone is very low to begin with. And so that's why at least they have that law to protect you in that situation. So you should feel comfortable doing it. Now, the only caveat is that applies to United States airspace. So once you're over the ocean, I don't know if there's any laws that apply because no one owns the ocean. And if you're over another country, you're technically responsible for knowing the laws of that country. So that the biggest issue is you're flying over Europe, and it just is changing as you're going. And there are some countries, and I don't know which, that require you to help if you are trained to. Now, how they could prove that you had the training and were
over their airspace.
And you were over their airspace, very difficult. But just be aware that exists. So there are people out there that have one alcoholic beverage at minimum to say, I'm inebriated. I can no longer help. It would not be ethical, just so they can get out of it in that situation. But yeah, so technically in Europe, it could get a little bit more complicated in that situation.
Doc, what if you were practicing paramedic and you're on a flight and you run into something that obviously we would call med control for, and I can't particularly just pick up my phone and call UH Geauga, UH Drive Me Anywhere and say, hey, I need to speak to a doctor. How do you go about that?
So in that situation, if it is one of the airlines that has that's connected with a physician, you could always ask, but knowing that it could take like 5 or 10 minutes to get that person on the phone based on the process, you're allowed to do anything that is in your scope of practice that you've been trained to do. So I guess it's even more broad than scope of practice. If you were trained to do something and where somebody deemed you competent, even if it's not your scope in your state, you could theoretically do it. The more further you get away from your scope of practice, the harder it's going to be to argue that you are technically competent and was in your wheelhouse to do. But this is also the odds of you, one, doing something so grossly wrong and outside your scope and somebody sues you is very unlikely. So I would just argue, if you think it's the right thing to do and you think you could do it right, you're probably okay to do it.
Well, they don't have like ET tubes or maybe a scalpel.
Not even that.
Not a scalpel?
No.
I can fix a lot of things with a 6.0 ET tube and a scalpel.
That's true. So you're basically stuck with a BVM and an IV.
Oof.
Unless you decide to pack that stuff in your carry-on.
Yeah, but then I got to worry about having it be found and
that's
me
true.
explaining who I am.
You got to make it through.
Yes,
you got to make it through TSA.
I'm legally allowed to carry this stuff, even though it's not prescribed to me.
I don't think the scalpel in your carry-on will probably fly very well.
Probably not.
You're going to meet some new friends at TSA.
Yes.
if you
Be on a no-fly list.
I've been stopped many a time by TSA.
Yeah, I think it's some free examinations. You talked a little bit about fitness to fly and how you as a physician got involved in that. What's that all about, and who's the population that you were really geared towards doing that for?
Yeah, so fitness to fly is something that ideally I never had to do because it should have been done with their own doctor or somebody before they ever arrived at the airport. However, we know how people are. They don't do this. They show up at the airport and they go to the gate agent and say, is this a problem? And most of the time the answer is yes. Now that you told us, we have to do something about it. But it's very frequently making sure that somebody is unlikely to have a medical emergency at altitude. That's like most of what we're trying to do in these situations. So it's the COPD patient who wasn't on oxygen at sea level, but maybe gets slightly short of breath when they're walking upstairs. They're probably gonna have a bad time at altitude because they're failing their little stress test, ambulatory pulse ox test when they're walking. And so theoretically, they should have told their doctor that they're planning on flying. Their doctor should say, ooh, we should probably get you a oxygen concentrator that you could bring with you, because you can't bring your O2 canister, which is a bomb at altitude. You need an oxygen concentrator to get you through your whole flight in that situation. And so if they ask, I would actually probably just tell the flight attendant, not the flight attendant, the gate agent, like, how does this person look when they're walking? Are they huffing and puffing? Because if so, they are probably not fit to fly, and they need to get this evaluated before we let them on the plane. If they look fine, then they're probably going to be okay in that situation. Ultimately, they'll end up being my problem in a couple hours if I let them fly. So I'll have to figure that out in the moment. And then the other situation, so the interesting one to keep in mind, if this happens, God forbid, anyone here, is if you get in a traumatic situation, you have a pneumothorax, pneumos are often no fly for a couple weeks. The reason is if you have any air in your lungs, when you get depressurized or at altitude, that air will expand, and so your very, very small trace pneumo can become tension physiology very, very quickly.
Real quick, yeah.
Because air will expand in all cavities. That's why you can have sinus pain, you can have ear pain, because that air is expanding. You can have a lot of bowel pain because the air that's in your intestines can expand. So anything that led to air where it should not be needs to fully resolve, such as any intra-abdominal surgeries, the pneumo, all that stuff. So if I have a patient in my ER that is here from out of town, they get in a car crash, they get a traumatic pneumo, they're stable, we take care of it, I would have to tell them, like, you can't get on a plane for 2 weeks.
Right.
So you're going to either have to drive home, take a train, or wait 2 weeks, and
here
then
for a while,
you can fly afterwards. So it's just something to make people aware of.
Yeah, no, it's a big deal, and probably not often thought of. So,
Have you ever had a Benz diagnosis on one of these flights?
I have not.
Okay.
But that is very relevant, because most people fly to these Caribbean or tropical islands to dive. And if they do have some decompression-related illness, it is likely to get worse when they get to altitude, because they went from a high-pressure system, higher than sea level, in the water, then they get depressurized to sea level, and then they get in a plane and get even more depressurized. So lots of divers often will not dive in the 24 to 48 hours before they get on a plane for that reason. But some say, you're going on this trip to dive, you're probably going to dive every day.
Of course,
and that can lead to some problems on the way home.
Yeah, get it in.
That's a good question.
Well, I think of the house episode first.
Oh, no.
Second, well, because I dive too when I go, and I pay very close attention to when's my last dive and when am I going to get an aircraft, because I don't want to go through that.
What's the standard guidance for that's told to divers?
I think it's 48 hours, but I always check before I go. And honestly, if you're going to a reputable place you're diving, they will remind you and ask you to be like, don't dive.
When are you leaving?
Yeah, makes sense. Because people want to dive as much as they can, but it can lead to some problems.
Yeah.
Awesome.
I didn't know you scuba dove. That's pretty cool.
Lots of things.
Yeah. That's more my style too.
Yeah. All right. Well, let's take a little break here. So, I got ahead of myself, and I forgot to introduce the fact that we are live here at Wakeman Fire Department in Huron County, and if you guys would like to introduce yourselves and tell us a little bit about your department and your jurisdiction and what you're all about.
Well, welcome. My name's Nick. I'm the EMS coordinator and a lieutenant at the Wakeman Fire District. We cover Wakeman Village, Wakeman Township, and Clarksfield. We provide a backup ambulance service as well as primary fire protection for our district. We have a couple other fire agencies in the county with us, Townsend Fire and New London Fire. They're coming to support us in our journey to make EMS better in this area.
Awesome.
We have a little token.
Yeah, little token for you.
Oh, here you go.
We certainly appreciate you having us out here and a little bit on short notice. So, and then Caleb, we have in front of us here a couple of oxygen masks, and as it turns out, one of our guests today actually has some history with this.
Yeah, so,
Michael, you want to tell a little bit about it?
So Michael Bloom here is with Cleveland's Hatsala Group, and he might be able to tell you a little bit about what he brought.
So my grandfather, Aaron Bloom, of blessed memory, actually invented those masks in the late 1950s. He worked for a company called Sierra Engineering. He was an aeronautical engineer, and he was located in Sierra Madre, California, which is in the LA area. His company ended up getting bought out by Scott, which makes the Scott firefighter masks.
Yes.
And all of that. That same model that he invented, you have one sample over there on the right, and then on the left is the current model. So it really hasn't changed that much since he initially invented it. The picture on the bag is actually still the same.
It is still the same.
So that's it.
Well, thanks for traveling to be here to show us that.
Yeah, I appreciate
thought
you
one of the really
appreciate
cool
bringing it
parts,
up.
like he had just mentioned, was there really isn't a lot of change between those two.
No, it's the exact same.
It gets the job done.
Yeah, it's good. Yeah, it's got the exact same. Both the old and the new model. It's got both the same imagery. But
Tube bag and mask.
yeah, that's awesome, Michael. Thank you for bringing that out.
And so this comes up frequently. People will ask when they're trying to do the fitness to fly, well, Doc, can I just use the mask that falls down if I'm having shortness of breath? And the reason is no, because one, they all run at the same time, so they're just going to fall for everyone, so you can't just use it for one person. And two, the whole point of these masks is to get you enough oxygen for if the cabin gets depressurized to get the plane low enough that you could breathe at that altitude. So we can't breathe at 30,000 feet, there's not enough oxygen. But if we can get the plane low enough, even if there's a hole or a window is blown out or something, then we can start breathing at least enough to oxygenate our brains. And so this, the way it creates oxygen is that it creates a chemical reaction that creates oxygen, and it lasts for maybe 5-6 minutes, not very long, but it's enough time for the captain to get that plane low enough, and then they can get to a safe place and land.
Is that the expected right on cue?
So I think they mentioned they run 250 or some calls a year, and of course, we're here and they go on the call count.
Oh yeah, no, I'm sure John.
Per usual.
I'm sure Dr. Hill's got the call counter clicking up right as we speak.
Per usual.
And I think we talked pretty much all about this stuff. And then, are there any cases that you handled that are, specifically memorable to you?
Oh,
that are just the outliers that were like you rolled back over and be like, I can't believe that just happened.
To be honest, I can't think of any off the top of my head because it's been 4 or 5 years since I've done this. I bet if you asked me 4 or 5 years ago, I had a few. But yeah, I can't think of any off the top of my head, to be honest. I mean, there's some people, for the fitness to fly, like some of the questions people ask, like this was in the middle of COVID, and you couldn't travel with COVID, like, I have cough, congestion, sore throat, could I travel?
No.
If you didn't say that, then sure, but because you said that, absolutely not. I don't know what you thought I was going to say.
Yeah. And have you ever had to get involved when medical providers were trying to provide assistance, or is the biggest cross section there people that specifically have had training?
I rarely ask the level of training because it's kind of easy to figure out pretty quickly based on what the captain is saying, if this person has any idea what they're doing when it comes to the medical professionals. The biggest hurdle was when the captain is being told by the medical professional that we have to divert the plane right now. And so the captain is freaking out, like somebody's telling me we have to divert the plane, and I'll have to frequently try to talk them off the ledge and say, well, hold on a second, like you're free to do that, but maybe I can help you do a little bit more now and see if things get better. And most of the times things do get better. So if you're the one up there, just remember that it's the captain's call, and that most things are not needing diversion. Really, it's 1 in 30 or so, 1 in 20. It's not many whatsoever. So just it's better to keep calm and realize that if you lie the person on the ground, they're probably just gonna get better on their own.
Yeah. Huh.
Don't freak out the captain. Unless it's really bad, right? Like the things that I would just absolutely recommend landing would be like somebody who's clearly having a cardiac event. Like if somebody's like Levine's sign, clutching their chest, pale, diaphoretic, you don't have a 12 lead. I just am going to assume that person failed his stress test when the cabin got depressurized, and he needs to be landed right now. And so that's one, like cardiac sounding chest pain at altitude is only going to get worse. If somebody is seizing by the time I get them on the phone, that means they've probably been seizing for 5 minutes or more. They're meeting criteria for status epilepticus, and they're pretty far away from a benzo unless somebody happens to also have a seizure disorder and have like PR Valium or something like that. Like we're very limited in what we can give.
Wow.
So it's like seizures and cardiac event is the ones that I'm going to be very, very worried about and say, ooh, like we gotta consider diversion right now. We don't have time to think.
Yeah.
And strokes probably.
And that's another good one, right? Like if it's like stroke symptoms, TIA, I mean, like we're gonna definitely recommend landing for the obvious reason that's time sensitive.
Sure.
You're bagging somebody, probably going to divert. He's fine. I'll squeeze for the next 2 hours.
Or if you're at that point, he may not survive.
True.
I'm definitely going to say divert it, but if somebody's in, like for instance, I was thinking about cardiac arrest.
Respiratory arrest. They got a heartbeat, but I'm breathing.
If it's cardiac arrest, it might, especially if it's somewhere, I might just say, you know what, like you're free to land that plane. Obviously, I wouldn't fault you for it, but there may not be anything to do. It just is a really horrifying situation.
So,
I wouldn't say age probably plays a difference, right? If one of us go into cardiac arrest on an aircraft, we're likely to intervene and do something more than, well, grandpa's 85 years old, has a heart history, and goes into cardiac arrest.
That's true. The other thing is that people who are on planes are typically even though they may not be taking care of themselves in the 24 hours before, are a healthier patient population than the general public, because typically people who are not very healthy or well are not looking to travel by plane. It just is not always correlated.
Yeah, kind of self-selecting group there. Yeah.
One of the questions here, I think, was being asked: is there a morgue on an airplane, and what do you do if somebody does expire?
Yeah, so there's definitely no morgue. But yeah, I would probably say I would put this person where there are no passengers. They might just put it in like the back of the plane. I mean, there's always like those areas where you can pull the curtain or something like that, but that is just a really unfortunate situation. That does happen, right? Where people are over the ocean, they do expire even if somebody's working them for a little bit, and then you just have to put the body somewhere, which is really sad.
Are there body bags typically on aircraft?
That had never come up for me to ask. I don't think so. Just like everything else, there's no, that's weight, and so they don't want any weight that they don't think is necessary. They're hoping people aren't dying enough on the plane to need body bags.
It'd be nice to zip it up.
What about an incidental, like maybe crime scene? You might have a victim, and then does everybody in the plane then get secluded to the plane until this is over? Or?
I have no idea. I would argue that is not my jurisdiction as
out of
the physician who's involved.
Fair enough.
But that's entirely possible.
Now, we talked a little bit about some of the technology in the form of like an AED. Are there other fairly basic things like pulse oximetry? Can they take a blood pressure, stethoscope? Are those kind of basic assessment tools, are they available?
There's a stethoscope, there's a manual blood pressure and cuff, and that's it. So if you want a pulse ox, I don't think they come standard with those finger pulse oxes. I mean, some people pack them, and they have them with them. So just if you're worried about SAT, you can ask. But
Ask around.
I'm not 100% certain on that because I have been told a SAT before, and so I have to imagine that maybe they do have that finger probe, but I'm not sure. I don't know how else they would have
I
gotten
might
it.
start packing mine, just in case.
Take your scalpel out, put the pulse ox in.
Yeah, exactly.
I
Oftentimes,
think a
if
lot
they're
of
saying,
smartwatches have SpO2 on them also.
so that's entirely possible. I got that information is they may have put someone's smartwatch on them or something. I mean, ultimately, if somebody's saying they're short of breath, I don't need to know if they're hypoxic. They're going to get oxygen in that situation.
Right.
And there's enough oxygen on the. I mean, I don't know what size cylinder, but they're 2 very small cylinders. It's probably enough oxygen to run 4 to 6 liters via nasal cannula until you basically land that plane right away. It's not meant to be like, oh, they feel better on oxygen, let's continue on. We're going to land it if they need it in that situation because we don't have that much oxygen.
So we're not CPAPing these patients.
Oh no. Although the guy I sat next to on my last plane ride was trying to plug in a CPAP, that did not go over well with the stewardesses for obvious reasons.
Oh, wow. Wow. If somebody does have medications, bronchodilators, nitrates, whatever, are there any risks with the altitude and, again, changing physiology by taking? I guess I'm thinking mostly about the nitrates, right?
So there is nitro in the
kit?
EMK.
Okay.
And
Of all things.
I know. I think that comes from like old guidelines, and the EMK was kind of created many years ago. But I do laugh. They don't just have one nitro; they have 25 tabs because it's
But is that just one
full
bottle?
container, one full bottle of nitro. So that's just. I think that's very funny. If everyone's having chest pain.
Once
That's
that,
not an explosive.
but once that bottle gets opened, you only have a few hours.
That's probably why they have a
or something?
standard container of it, and then.
Yeah.
I thought pharmacy wants us to discard it.
Correct. Once they're open,
And I think that's
They're
probably it's
supposed
cheaper
to-
to have one container than like one tablet or something probably.
Surprised
they
wouldn't
might not
go
make
Go
them
Nitro,
individually
you know,
packaged.
Like the packets Go Nitro, like
Yeah, but Go Nitro went out.
Yeah, that's no longer. But that would have been a perfect application
Yeah.
for that, assuming everybody knew how to use it.
But you can use any of these other medications. I mean, ultimately, I don't know of any medication that would make things worse at altitude as compared to ground level.
Yeah. Are there dextrose preparations?
There is, yes.
Just oral glucose or
There is
D50?
oral and there is IV dextrose. I don't off the top of my head know which. I suspect it is D50
50.
because it's the smallest. But yeah, like obviously try to use the mouth if we can get away with it in these situations. Because you don't necessarily need to crack the MK if somebody's awake enough. Just juice
Orange
and
juice, yeah.
something else is sufficient.
Yeah. Is there like a passenger count where they have to have an EMK or just any commercial flight?
I believe it is any commercial
Any
flight, and
commercial
that is
flight.
just because that is. I think some law requires it, and I
Yeah.
just don't know off the top of my head which law.
So if I'm on a little puddle jumper from here to Minneapolis or something, I should expect to have that same
Yes.
access to the same access
Yes.
to tools that I would have.
I assume it is all commercial airlines, no matter the size.
Yeah. Any idea if like a private jet would have anything of the
question.
sort?
I actually don't know on that.
Or would they even have the ability to contact you? Like, would they
Yeah.
even have a contract to...
Yeah, they would have to have a contract because all these airlines have a contract with StatMD, and there's another company or another organization I think in Arizona that does something similar, and they have a separate contract with different airlines. Now, obviously, that's based on 5 years ago. Things may have changed. There may be other organizations that do this.
Do flight attendants and airline workers, do they have some training or understanding of what's in the, or is it just I have to know to ask for it for
Right.
them to come get it?
Yeah, so
for them to
they
get
should
break-
know that there's an EMK and say, hey, do you need equipment? We
Yeah.
have an EMK
Yeah.
as far as it might go. But as far as them having the training to do stuff,
something.
I don't know if there's any mandate for it. And I don't
Yeah.
think when I would interact with these flight attendants that they would have any additional level of expertise. Like they could follow simple instructions in terms of stuff, but it was the same as if I was giving those instructions to another layperson without a medical background. They were very helpful. Like they were always trying to be like, hey, what do I need to do? We don't have any EMS or medical personnel on this plane, like how can I assess? Like they try
That's
very hard.
happened where there's at least no one's volunteering to say that I'm
Yeah.
medical.
Exactly. And then it was funny when I was talking to the flight attendant related to the last one I was on, where I clearly wasn't needed because there was like 6 other people. And he joked, he's just like, yeah, it's feast or famine. We either have a dozen people or no one at all.
Or no one at all.
It's never at least one person for every call.
Huh. What about, I imagine you would have the same language barrier issues that we have on the ground. It doesn't change things. I guess as the physician, you'd still be dealing with somebody who has to speak English, because all air traffic control is done in English, worldwide.
Yeah, so I've never had to deal with at least a captain that was speaking a different language. Even when we did stuff for airlines that were not from the United States, because we did contract with with a few airlines that were predominantly in Asia and Europe and that kind of thing, and it was never an issue.
Yeah. Caleb, questions out there?
Not yet.
No? What? All right, just get into opinion now. What do you think the future looks like in this space? I mean, it seems like there's Wi-Fi on every flight. Is it really going to be this cumbersome system in the future to get a hold of a medical direction, or can you foresee essentially like teleconferencing and
I think it'll get better, but I think right now, even when you use Wi-Fi on a plane, it very explicitly says you cannot make phone calls. So I think phone calls or kind of video calls on an airline are very much restricted, and that probably has to do with certain regulations.
Sure.
So I bet if those regulations opened up, more things could be done, but I doubt they will, because I think ultimately they want to keep things pretty controlled on an airline, just to kind of keep calm and keep the situation under control in general. So I don't know what's going to change. It might be much easier to communicate with the captain. Sometimes it was very unclear, like not unclear, it was like it wasn't like a clear signal, and it was hard to hear cleanly, and I think that will only get better.
Like static and broken.
There was some static and broken, and it often was like a radio where I'd have to click the number 1 to talk, and then let off the 1 so that I could hear from them. So it functioned like a radio, even though it was off my phone. And so I think that things will get better and faster, but I don't know if they'll open it up for anyone to call anyone, kind of thing.
Yeah, no, that wasn't my question, but I'm certain programmatically they could say, hey, this is the one device that is allowed on this flight to have.
That's entirely possible.
Teleconferencing and allow it. I'm pretty sure there's somebody sitting at this table that could figure out how to make that happen.
He's busy.
He's busy. Yeah. Maybe that's going to be your claim to fame.
That'd be cool.
I
don't know. I mean, of all the things we've talked about, the one thing that I'm not in this podcast so thus far has been like ECMO. I think ECMO is totally taking a right-hand turn, but
hopefully we're not doing ECMO on a plane. That's extreme.
I mean, why not? Game on. I think having push-button ECMO, like we've got essentially almost push-button CPAP for EMS providers. We've got really easy to do auto-controlled vents for
our vents are getting much. Yep.
And certain vent manufacturers have auto modes that
are very impressive, that analyze your specific lung physiology and optimize the rate and the volume. It's pretty impressive.
Breath by breath.
Yeah.
I think for overall medicine, if we get those push-button ECMO machines where you and I are cannulating, like the right person, right? 40s and went into cardiac arrest and has all the right things, but we're still an hour away from ECMO center. If I can initiate ECMO with more push-button authorities, I can cannulate anything.
Sure.
I think that's where future's going to go. We have telemedicine already, and I think maybe moving. Now that we have more high-speed data connections, Starlink being one of them with like the lower stuff, that we have a higher speed data connection. And we even internally in UH have kind of played around with even provider level stroke evaluation.
telemedicine, yeah.
From a telemedicine standpoint. So I could see it going that way, but it's still hard because you still don't have those resources at the patient's side. It's very different from an EMS standpoint. Is you're driving around a $250,000 ambulance that's got $1,000 worth of medications in it and another 50, 60, 75 grand of equipment that can all if Luke. Wow.
You're at Lucas plus monitor.
Yeah, Lucas and monitor.
I don't know what ambulance you're outfitting this day and age, but
Yeah.
Things have gotten more expensive. Firefighter Lucas sure isn't on that flight, unfortunately. You've got AED, but not a monitor.
Nope.
Some airlines do have more stuff. So the one that is most equipped is, pardon?
It's Air
So Air Force One, they might have ECMO. Like they may actually do ECMO on a plane. But Emirates, like obviously that's a very luxury airline.
Yeah.
They have their EMK has things like Valium and other benzos that very much are we're going to open up the EMK just because if you're feeling a little anxious, we'll give you something. They also have a whole.
So what I'm flying.
They have a full device. I forgot what it was called. I used to know, but it it is a full, almost like a monitor. It probably has everything. They may have their version of a cheaper monitor.
Cardiac monitor.
Yeah, so they can do a lot more than anyone else. So if you're gonna have a medical emergency, you might as well be on Emirates.
Be on Emirates, all right.
I mean, unfortunately, the LifePack 35 and other. Obviously, we know the LifePack much better. They have streaming capabilities now. You can actually stream those full telemetry data links.
Yep.
Are we going to put a third pack on 35 in every aircraft? No, but having some small device, and I've seen recently that might be a cool thing if you get live 12 leads. There's some devices out there that's literally just a box and a strap you strap around them.
Yeah, put it around
push
there.
a button, and then the cardiologist reads it around the world. But you do that, push a button, we get to see a 12 lead. You go, yeah, that's a LAD. You need to divert now.
But I guess the question would be if you have a good story for an MI, even the EKG might look normal, and you're still going to say, we probably need to.
We were doing one
get you
review
off
and I
there.
showed these
We
two
were
guys
just talking, yeah.
that EKG, by my interpretation, the story was I'm having an MI. I looked at the EKG, I didn't see reciprocal changes. It looked like pericarditis. They didn't give meds, they talked to online med control, they got there. Long story short, 100% inclusion of LAD. EKG looked like pericarditis. Story was MI.
Hello.
Oh, hello. But yeah, and that we're always going to, and I tell patients that too from a chest pain standpoint. I'm sorry I bothered you to come to the ER. I'm like, you're having you came here, you saw a physician, we got a chest x-ray, we got an EKG, and we did high sensitivity tests on your blood to make sure you're not having a
Now
heart
we know
attack.
things look better.
Yeah. Now
We didn't know that.
I'm very confident in sending you home.
Yeah.
We risk stratify you into very low risk chest pain. You have a less than 1% chance of having a major cardiac event in the next 6 weeks, but that's because I have an EKG, I have troponins, I've personally assessed you. I feel comfortable sending you home, and there's times that, man, I don't like this story. I don't like how this patient looks. I'm still going to admit them. And we've also seen patients that we do EKGs on them. They don't meet criteria when they hit the door. 10, 15 minutes later, their meeting's done.
There it is. Yep.
Well, that's the thing is an EKG can only rule in a heart attack, can't rule it out.
Yeah, and it's a snapshot, and it's 12 seconds in time.
So let's assume one does have to divert. Are you or those comm specs? Who's making that contact to set up all of the EMS response on the other end? Was that on your team's side, or was that something that it was kind of left up to the airlines at that point?
That was part of the service that StatMD provided, was that our comm specs arranged for all that. So there was, the comm spec would be listening to the entire call. They'd be documenting everything for me, which is really nice. So there is a paper trail that they're documenting the whole thing, and there's a recording. But then they would also kind of, obviously in the background, be like, oh, this is sounding like a diversion, and pulling up all the right stuff. And then when they pull the trigger on that, then being like, okay, we'll have resources ready, and then the ComSpec takes care of it. So that's kind of like a partnership between us, where I'm making the decision, the medical decision making, and the ComSpec is kind of taking care of all the other administrative stuff as well as linking in care. So they were a fantastic asset and very good at their jobs.
Did they also pre-notify hospitals, or was that kind of just...
That was all part of it, yeah.
Oh, really? Including that? Wow. All right, so they got local EMS there and also said, hey, we're
be aware this is happening.
Be aware there's a flight inbounds. This is what we know. And don't know when it's going to get to you, but...
And then for QA...
Just like every other EMS report.
All right.
And then
We'll be there when we get there.
For QA, they would actually follow up on the patient. All diversions, we would follow up on what happened to the patient. Because ultimately, if we found out we keep on diverting something that turns out to be nothing almost every time, then we can get that feedback so that we consider that in the future. Because ultimately, we're trying to divert when appropriate. Because it's a big hassle for airlines and for a lot of travelers, right? If your flight gets diverted and you miss some other layover, you miss a day of your trip. I mean, that's really frustrating. I mean, yeah, you want to take care of patients, you want bad things to happen to people, but you also want to get to your trip and go on vacation.
Conversely, were you guys QAing the ones that you did get involved in but didn't divert to ultimately see if that was a correct decision not to divert? Or since there is kind of interplay there with the decision making of the pilot, is it kind of a moot point?
So we would, I guess you could argue that things didn't go well if we got another phone call. So ultimately, no news is good news. But if we heard back again and things were not going well, then that would be considered like maybe we should have.
That was your.
Then again, maybe not, right? It may have been very appropriate to do the wait and see approach based on things, and just because things don't go well doesn't mean it was the wrong decision in that moment. But really, yeah, if there was some miss or some concern, that would get fed back to us, because ultimately, like, we're trying to improve also. Taking these phone calls is a skill like anything else, and you want to get better at that skill by getting feedback.
Yeah. How does, once that plane lands, if nobody's ever worked in a service that was close to an airport, how do they physically go about getting the patient off? Do they still have to do the whole taxi process and go up to the gate? Do they stop short somewhere else and throw some air stairs up on the side and carry them down? What's the...
I actually don't know on that, because that was often handled by the local service, but they definitely prioritize getting them off, and so I assume, especially because if you go to the gate, now you're stuck inside, right? So they will pull the ambulance right up, because they're obviously contracting with these ambulances, and probably, I would assume, pull stairs up, get that passenger out, and then, I mean, if they are able to just refuel and take off, then they'll refuel and take off, depending on the situation.
Sure.
Because they do need some form of refueling, because obviously they were not planning on taking off. Is a lot of energy, and so they need a lot of fuel just for that.
Yeah.
Well, they might have dumped fuel to get to land.
To get down, depending on, absolutely.
And that's the other thing is like that's a negative of it. If you dump fuel, oftentimes you're not really looking directly what you're dumping it over, and it could be something not ideal. I think there was like something that hit the news where some airline dumped fuel in the vicinity above like an elementary school, which was not ideal because kids were playing during that. So I don't know the details, but I remember that made the news in that way.
Kerosene rain, okay. And if there is somebody that is traveling that has medical history, I mean, what kind of advice would you have for them to not be the case that we have to get up and intervene on?
Yeah, so the first thing is if you have any question, ask your doctor, right? It's much easier months prior to your flight to say, am I safe to fly? And they could do all the tests necessary, and if you do need oxygen, then you could purchase a relatively inexpensive oxygen concentrator and bring that with you and be totally fine to go in that situation. And if you forget to do this and you're getting on, and you're at the gate, ask, because you can talk to a physician, like such as myself when I did this prior to getting on the plane, right? Because if you're not, I know everyone wants to say, well, I don't want the answer to be no, I can't get on the plane, but if you should not get on the plane, it's better to find that out before you fly than before you're at altitude having a medical emergency. So that's why it's, when in doubt, ask the question, and ideally ask the question months in advance.
Take all your medications in the morning, especially take your beta blocker. You don't want to go to AFib with RVR altitude.
Don't take them in conjunction with copious amounts of alcohol.
Also that.
There was one more memorable where I felt bad for this person, where Somebody unfortunately broke their jaw for one reason or the other, had their mouth wired shut, and needed to fly home. And if your mouth is wired shut, you need to have pliers to basically cut the wires to open your mouth if you start to vomit or have something happen. And I was informed that they weren't sure if they could fly because they packed the wires and wire cutters in their checked bag instead of their carry-on. And I said, ooh, that's unfortunate. You need the wire cutters. And they're like, well, the luggage is already loaded and going to go on the plane. What are we supposed to do? I said, get new wire cutters, because ultimately you cannot get on that plane if you cannot potentially cut the wires if you vomit.
Get access to the airway.
So if you ever, hopefully don't break your jaw, but if you do, make sure you have the wire cutters on your person.
So we have one online question. It's from our friend Wes Green. Do you think this job helped you with online med command calls?
I think it helped me think about more unusual situations, because even med command calls is a skill in itself. It's a different skill, but you have to think about, can I get important information by asking only one or two questions, not many more than that, and get enough information to, one, disposition the patient, and two, give the right order to the crew. Like, and especially if the patient's crashing, you don't have much time to like say, oh, instead of resuscitating this patient, let's have a full conversation on what's going on. It's not always doable. So kind of, how can I maximize information gain and transfer in as few of words as possible? And that's a skill that I'm still to this day trying to get better at, because it is not easy. And then everyone here uses a radio every day knows that is something we're all trying to get better at. And it's sometimes very, very hard.
It's an art, sure is.
It's a good question, Wes.
Thanks, Wes. All right, well, we're getting kind of towards the end here. John, do you... Since I'm doing everything backwards here, you want to key up the sponsors there?
Sure.
If you want to talk to them.
So this evening is brought by our friends at FirstNet and CradlePoint. So all the streaming that we're doing right now is using FirstNet's network and CradlePoint hardware. It's going out live from the fire station. There's a QR code up on the screen. FirstNet's open to anyone that is police, fire, first responders, hospital. I personally use it, love it to death. So the same deal that we get is also available to you guys.
Passed along to you, yeah.
We obviously have our website, prehospitalparadigm.com. It's got all the show notes from today, videos, the audio. Our audio is always available on any of your podcast apps you like to use. We've also got our education site there, so free Ohio CE. I know it feels like I'm a broken record saying this. We are very much actively working on getting CAPC credit. I would expect that to be our goal for 2026. Yeah. So we've actually already got the classes built. We're working through getting our institutional certification for that, and then once that's live, you'll have a lot of access to both the podcast education as well as the education that University Hospitals puts out internally as well, so be able to get that online. I'm also hoping to throw in some extras for if you're in Northeast Ohio, if we're doing hands-on sessions, to get you even more CAPC credits for National Registry, so I think it'll be worth everyone's while. So that's my sales pitch, I guess, for the evening. Thanks for
that was awesome, Dr. Singer.
Thanks for having me.
Thanks for coming back. It's always a good time, man.
Yeah.
Well, thank y'all. We'll catch you next time.